Hello, this presentation will address patient needs related to alterations in oxygenation, ventilation, respiratory. Let's begin. The first topic we're going to talk about is in chapter 10. So this is not in the respiratory chapter. It is in chapter 10, and this is sudden infant death syndrome, also called SIDS. This is an unexplained death of infants under a year of age, accounting for about 40 to 50% of all deaths between 1 month and 1 year of age. The proposed risk factors include an underlying infant vulnerability, such as a brain abnormality, a critical incident in the fetal developmental period, or an early neonatal life, and an exogenous stressor, such as prone sleep positioning. Risk factors include prematurity, low APGAR scores, low birth weight, twin or triplet birth, race in decreasing order of frequency, so most common in Native American infants, followed by African American, Hispanic, white, and Asian. Gender, more in males and females. Age, most common in infants between 2 to 3 months of age. 95% of cases occur before 6 months of age. Time of year, more prevalent in the winter. Exposure to passive smoke, this reduces arousal to hypoxia. History of cyanosis, respiratory distress, irritability, and poor feeding in the nursery. Excuse me. Sleep habits, highest risk associated with prone sleeping, use of soft bedding, overheating, which is due to thermal stress, co-sleeping with an adult, especially on a sofa or non-infant bed, higher incidence in co-sleeping with an adult smoker. Infants co-sleeping with an adult are at higher risk if they are younger than 11 weeks. So please do not sleep with an infant inside of your bed. They really do need to be put in their own separate crib or bassinet. There is a lower incidence in infants if they are put to sleep with a pacifier. Maternal and family. So risk factors here include maternal age less than 20 years. Is there a history of smoking and illicit drug use? This increases the incidence 10 times. Anemia, multiple pregnancies within a short interval between births. A history of a sibling with sudden infant death syndrome. This actually increases the incidence 4 to 5 times. Low socioeconomic status, crowding, poor prenatal care, and low weight gain. Here are some protective factors. Breastfeeding. Nurses must promote the Back to Sleep campaign. All infants from birth to 6 months of age must be placed only on their back to sleep when they are going to sleep. They should also be put to sleep with a pacifier. A thin blanket can be placed on the infant as long as it is tucked at the level of the infant's waist. Really, nothing soft should be in the crib. Infants should not sleep in the parent's bed, but it's really nice for them to sleep in the same room. This is preferable until the infant is 1 year of age, but at least for the first 6 months of life. Room sharing decreases the risk of SIDS by as much as 50%. Infants with gastroesophageal reflux disease may be placed supine unless there is a condition with a higher risk from death than SIDS. And this is only as directed by their doctor with extreme caution. So a child is brought into the emergency room with SIDS. What next? We need to get a history by the parent or the caregiver. We need to ask, what time did they find the infant? How did they look? Who did they call for help? Was there a change in infant position? Was the blanket disheveled with the infant clutching it? Was there frothy blood-tinged secretions from the nose and mouth? Parents find infants in the morning, often after a quiet night. This can occur after a mild respiratory illness. Often the autopsy will reveal pulmonary edema and intrathoracic hemorrhage. The autopsy typically cannot distinguish between SIDS and intentional suffocation, but the scene investigation and medical history may be of help if inconsistencies are discovered. Nursing interventions in the emergency room. You want to provide the parents with a private area and a support person who reinforces that the infant's death was not their fault. Parents need to be able to express their grief in their own way and know that they are not being blamed for the infant's death. Prepare the family for the viewing of the infant. Describe how the infant will look and feel. You will say, Paul, that's the infant's names. Skin will feel cool. He will be very still. His eyes will be closed. They probably know this, but a gentle explanation demonstrates empathy. Explain that pulling of the blood on the dependent areas will look like bruises. Allow the parents to hold, touch, and rock the infant if desired. Viewing the infant allows parents a chance to say goodbye. Before bringing the infant to the parents, wrap them in a clean blanket, comb the child's hair, wash the face, swab the mouth clean, and then apply Vaseline to the lips. Reinforce the physician's explanation about the need for an autopsy. An autopsy is required for all unexplained deaths. You can say to parents, it's the only way we can be sure of what caused your baby's death. Answer parents' questions and provide them with sources for further information. Provide literature and a name of the local contact for a SIDS support group, as well as for the National Foundation. Parents may not be able to take in all of your answers at the time when they're in the emergency room. Many emergency departments and pediatric units have a social worker that provides ongoing contact with the family. Provide names of resource persons and phone numbers for SIDS support groups. Advise parents that surviving siblings may benefit from psychological support. Siblings often require emotional support in the weeks and months after the death. Social workers can help the family. Siblings often require emotional support in the weeks and months after death. Social workers can help the family obtain counseling and support for all members. Provide parents with a lock of hair, footprints, and handprints if they desire. Personal items can be placed in a memory book. This reaffirms the child's existence for many parents. Next, we're going to talk about acute life-threatening event, also called BREW, which is the acronym for Brief Resolved Unexplained Event. This is not missed SIDS. We used to call it that, but that is not correct. So know that what the parents would report here is color changes, hypotonia, choking, gagging, and they may require CPR. This condition can be associated with an increased incidence of SIDS. The treatment is home apnea monitoring. They may actually also be given a medication like a methylxanthine or caffeine, and the parents need to be trained in CPR. Next, we're going to talk about the respiratory system, and this is in chapter 21. Respiratory problems are the most common cause of illness requiring hospitalization in kids 15 years and younger. Infants until around 6 weeks, as I've seen it, as high as 12 weeks, are obligatory nose breathers and only know how to breathe through their noses. And therefore, if their noses are stuffy, they will cry because that's the only way that they're going to be able to breathe. The other thing that's interesting is that the infant's trachea is very, very tiny. So know that their trachea is about the size of the infant's pinky. So if you're going to use an ET tube, if that's necessary, know that it's about the size of an infant's pinky. There are many differences between an adult and a child's airway. They have a smaller nasopharynx, which means it is more easily occluded during infection. The lymph tissues grows rapidly in early childhood, but then it atrophies after age 12. They've got small nares, again, more easily occluded. A small oral cavity and a large tongue can increase risk for obstruction. And Ultimately, what happens is because of a lot of the soft tissue and the loosely anchored areas, they are at higher risk for obstruction and edema. Apnea. So this is when there is a breathing pause for 20 seconds. This is a concern. If an infant is apneic, you want to gently stimulate the trunk by patting them or rubbing them. Nasopharyngitis. This is the common cold. It can be caused by a wide variety of viruses, and this can be prevented with hand washing. Signs and symptoms. The younger child, you might see fever, irritability, decreased appetite and fluid intake, restlessness, sneezing, vomiting, and or diarrhea, decreased activity, abundant nasal secretions, which can cause mouth breathing. The older child, you might see dryness and irritation of the nose and throat, mouth breathing, chills, muscular aches, coughing, and or sneezing. Usually resolves in roughly 10 to 14 days. Treatment. The signs and symptoms is really what we're going to be treating. So antipyretics for fevers such as ibuprofen, and this is typically for children 6 months of age and older, or acetaminophen. You want them to rest until the fever is gone plus 1 day. Note that topical decongestants for infants over 6 months of age may be utilized. In order to avoid rebound nasal congestion, vasoconstrictive nose drops or spray should not be administered for more than 3 days. Before 6 months of age, you're going to be using normal saline drops. Note that decongestants work by causing vasoconstriction. You want to be careful if a child has diabetes because this vasoconstriction is systemic. Dextromethorphan, which is a cough suppressant, and this is something that you would use for a dry hacking cough. Note that the American Academy of Pediatrics stated that over-the-counter cough and cold medications really are not effective for children under the age of 6 years of age and may pose health risks. You can elevate the head of the bed at least 30 degrees. That will help to ease respirations. They may require oxygen with a humidifier or a cool mist humidifier. We do want to maintain the SaO2 greater than or equal to 95. Check vital signs and lung sounds. They may require a bronchodilator. You want to keep the child calm, provide appropriate diversional activities. If they require suctioning, limit that to 5 seconds. That might be done in conjunction with chest physiotherapy. Normal saline drops and suctioning may be done before feeding and before the child goes to sleep. You want to feed the infant with many breaks using a calm approach and not to exceed 30 minutes. Explain everything to the parents. Typically, this is something that is managed at home. You would call the doctor if the child isn't getting better in 2 to 3 days. Acute streptococcal pharyngitis. Here, the cause is group A beta hemolytic strep. Complications include acute rheumatic fever, acute glomerular nephritis, scarlet fever, impetigo, and pyoderma. Signs and symptoms: tonsil exudate, severe sore throat, a fever over 101, headache, petechial mottling of the soft palate, vomiting, abdominal pain, swollen painful cervical lymph nodes. Diagnosis: that good old throat culture. You're going to do a rapid stress test. It's ready in just a few minutes. Treatment is amoxicillin or penicillin for 10 days orally. They can use things like azithromycin, erythromycin, clarithromycin if they are allergic to penicillin. They will use some of the same palliative care as with tonsillitis, which we'll talk about in a moment. They are no longer contagious after 24 hours of being on the antibiotic. Warm saline gargles, ibuprofen, and acetaminophen may be effective in decreasing throat pain. You want to encourage the intake of cool liquid, ice chips, and flavored ice pops. Please remember to change your toothbrush in that 24-hour period once they've taken those antibiotics, because we don't want the person to reinfect themselves. Wash all mouth appliances thoroughly, like retainers or grinding guards. Call the doctor if they are not improving within 24 to 48 hours after the antibiotics are initiated. Tonsillitis. This is an infection or inflammation of the tonsils. It can be caused by a virus or a bacteria. Signs and symptoms include a sore throat, swallowing, breathing difficulty. There may be an offensive mouth odor and impaired senses of taste and smell. The voice may have a nasal and muffled quality and a persistent cough, fever, tonsillar swelling, which results in kissing tonsils. So they're basically so swollen that they touch in the back of the throat. Swollen lymph nodes, pain that refers to the ears, malaise, and decreased food intake. Diagnosis is a physical assessment. They will do the throat culture to determine whether it's a virus or bacteria. Treatment, we only use antibiotics if it is bacteria, and we already talked about the penicillin and the other medications. You can use warm saltwater gargles, lozenges as age appropriate for typically over 3 years of age, because we don't want them to choke. Antipyretics, warm or cool compresses to the neck, soft, cool foods, and rest. A soft to liquid diet is generally preferred. Warm saltwater gargles and warm fluids and regularly prescribed non-opioid medications, again, like that acetaminophen and ibuprofen, can be used to help promote comfort. Tonsillectomy and adenoidectomy. So these used to be done like a lot. They're not done with the frequency that they used to be done. So here, this is indicated for multiple reasons, including recurrent strep infections, peritonsillar abscess or hypertrophy that's causing problems with eating or drinking, sleep disordered breathing, and then other reasons as well. Typically, they will do surgery 1 week after being free from any kind of upper respiratory infection, fever, or sore throat. They will remove the adenoids for multiple reasons, including obstructive sleep apnea, otitis media with effusion, or recurrent rhinorrhea. Postoperative care. Here you're going to want to position the child on their side or their abdomen for drainage. Avoid suctioning except to remove an obstruction. Check for bleeding. Signs and symptoms of frequent swallowing, restlessness, a fast weak pulse, vomiting bright red blood, typically in the first 24 hours. And then again, at 5 to 10 days, you want to check for an increase in swallowing because this is an early sign of bleeding. There's a membrane that can form over the surgical site and it can actually dislodge, which would cause bleeding. You may use an ice collar or viscous lidocaine as a swish and swallow. You do want to avoid coughing, nose blowing, gargling, and throat clearing. They may have ear pain 5 to 10 days after surgery. This is a referred pain, and this is not uncommon. They may use oxycodone or hydrocodone for the first 24 to 48 hours, and then after that, using regular acetaminophen for pain. They can have fluids, diluted juice, and soft foods when they are alert, able to swallow, and there are no signs or symptoms of bleeding. You want to provide a clear, cool, non-citrus fluids, and you also want to avoid foods and fluids that are red or brown in color. We don't want to confuse them for blood if they vomit. Also avoid milk, ice cream, and pudding because that can also cause a child to clear their throat. You want to resume normal activities, typically within 1 to 2 weeks. Clinicians must not administer or prescribe codeine or any medications containing codeine after a tonsillectomy in children younger than 12 years of age because of the United States Food and Drug Administration's 2013 black box warning about codeine-related fatalities. Influenza. So types A and B are included in the vaccine, and type C, which causes a milder disease and is not included in the vaccine. More common in the winter. One is most infectious 24 hours before the signs and symptoms appear, and then 5 to 7 days after the onset of symptoms. It is spread by direct and indirect contact and lasts roughly 4 to 5 days. Signs and symptoms: dry throat and nasal mucosa, dry cough, hoarseness, photophobia, myalgia, hyperesthesia, frustration, fever, and chills. Diagnostic tests is a culture of the nasopharyngeal secretions. Prevention: let's prevent it with the flu vaccine for all children 6 months and over. So treatment really is symptomatic treatment. You can use Tylenol or ibuprofen, fluids to maintain hydration. Oseltamivir can be given for 5 days orally within 2 days of the signs and symptoms onset to children a year and over. This is good for types A and B. Zanamivir can be given to children 7 years and older, and prophylaxis 5 years and older as an inhaler twice a day for 5 days. This is also good for types A and B. A prolonged fever or appearance during convalescence is indicative of a secondary bacterial infection such as pneumonia and should be reported to the doctor for antibiotic treatment. We do not give aspirin or any kind of aspirin-containing salicylates to children that have any kind of flu-like symptoms. Really, we don't want to give children aspirin. There's a couple of exceptions, which we will talk about. But in general, no aspirin or aspirin-containing medications for children. As I mentioned before, we can prevent the flu with the flu vaccine, and children 6 months and older can get that. We still do ask if they have an allergic to eggs, but please note that an egg allergy now is no longer considered an absolute contraindication. An age-appropriate recombinant or cell-cultured product may be used for patients who refuse to receive an egg-based vaccine. Know that they can have a slight body temperature and body aches for 1 to 2 days after receiving that vaccine. That is normal. Also, they can have a local reaction of a little bit of pain and redness at the site. Otitis media. Here, the highest incidence is between 6 months and 2 years of age. And this is because they have a wider, shorter, and straighter eustachian tube. It typically decreases after 2 years and increases between 5 and 6, and then it is again uncommon after 7 years of age. Signs and symptoms. Acute otitis media is an inflammation of the middle ear space with a rapid onset of signs and symptoms of an acute infection. It typically follows an upper respiratory infection, earache, fever. They may or may not have purulent discharge. So know that just because they do not have purulent discharge, that does not mean they don't have a middle ear infection. Infant or a very young child, signs and symptoms they might have would be things like crying, fussing, restlessness. They may be irritable. They might be rubbing, holding, or pulling the affected ear. They may roll their head side to side. You might have a difficult time comforting the child. They may have a loss of appetite, and they may actually refuse to eat. An older child, they might cry, they might complain that their ear is hurting, they're irritable, lethargic, and again, loss of appetite. Chronic otitis media with effusion. Here you would see hearing loss, difficulty communicating, feeling of fullness, tinnitus, or that ringing of the ear, or dizziness may be present. Diagnosis based on signs and symptoms. You're going to look with a pneumatic scope, otoscope. Acute otitis media, you'll see a red, yellow, and bulging tympanic membrane with no light reflex or bony landmarks. Otitis media with effusion, you may have an immobile tympanic membrane, a slightly inflamed orange membrane with obscure landmarks and visible fluid. So treatment, they will do a watch and waiting for worsening signs and symptoms up to 72 hours in healthy infants over 6 months of age. This is okay, except younger than 2 years old if they have acute signs and symptoms of a fever and severe pain. So antibiotics for acute otitis media if the infant is younger than 6 months of age due to the immature immune system, or younger than 2 years of age with acute signs and symptoms of fever and severe pain, as I mentioned earlier. The first line antibiotics is amoxicillin, 80 to 90 milligrams per kilo a day, typically for 10 days, then younger than 2 years old. They may only need it as short as 5 to 7 days for 2 years old and over. Second line of defense would be your azithromycin, your cephalosporins, amoxicillin, clavulanates, a myringotomy. This is an incision into the eardrum that may be done by laser if they have severe pain or hearing loss. They may also insert pressure equalizing tubes. If frequent problems with otitis media with the fusion, they may do this. And what this does is this promotes drainage and ventilation of the middle ear. So depending on the doctor's orders, really determines their exposure to water. Really, you don't want water to go into the ear. Sometimes doctors will allow swimming in chlorinated water. We don't want soap or shampoo to enter the ear. The ear can be protected with a Vaseline covered cotton placed in the ear, or you can also just place earplugs. Note that the tubes may fall out. This is not an emergency. Just call the doctor the next business day. Typically, they'll remain in anywhere from 6 months to 18 months, and they usually will fall out during this time as the eardrum heals. If they remain in more than 2 to 3 years, then they will be removed. They may lay on a heating pad. This will help with pain. Also, it allows the ear to drain. Frequent otitis media can cause hearing loss. So you do want to do a hearing evaluation if there is fluid in both ears for a total of 3 months. We can prevent otitis media by feeding the child in an upright position or breastfeeding. Immunizations are also there that can help to prevent otitis media. No smoking around the child or in the home. Do not prop bottles. Although we want infants to use pacifiers when they go to sleep under 6 months of age. After this, you may want to consider decreasing or stopping the pacifier. Pain and fever will decrease typically within 24 to 48 hours. But remember, if given antibiotics, they always must complete the full course. You want to treat the pain and fever typically with acetaminophen or ibuprofen. Next, we're going to talk about epiglottitis or supraglottitis. This is a type of croup. It is a bacterial croup syndrome. It's an inflammation of the epiglottis that occurs mostly in children anywhere in between 2 and 5 years of age. This is considered a medical emergency, most often caused by HIB. Signs and symptoms include a rapid onset, agitation, stridor or frog-like breathing on inspiration and when supine, tripod position with the chin thrusting out, mouth open, and the tongue is protruding. They will have a sore throat. And then we have something called the 4 Ds of epiglottitis: dysphonia, dysphagia, drooling, and distressed respiratory effort. They can have a high fever, typically over 102.2, rapid heart rate and breathing. This child looks very ill. They may have an absence of a spontaneous cough, drooling, as I mentioned before, and that agitation. Diagnosis here, you're going to see a lateral neck x-ray. You'll see a large round epiglottis and a narrowed airway. Kind of looks like a stiff thumb. Do not examine the mouth or do a throat culture, as it can cause a laryngospasm, and that would obviously not be good. So you only examine the mouth if you are ready to have somebody intubate. Treatment, they will be in droplet isolation for 24 hours to prevent any transmission. Open the air with intubation if it is necessary. They'll be on antibiotics, ceftriaxone or cefotaxime and vancomycin. These are typically your first-line antibiotics and typically given for 7 to 10 days. They may use corticosteroids for reducing edema, and that might be beneficial during the early treatment phase, as well as antipyretics. If the child is intubated, they will be in the PICU. Typically, after three days of antibiotics, the epiglottis is near normal, and then they can be extubated and then transferred to a regular unit. Often they're going to be given high humidity in a cool mist tent. We want to keep them head of the bed elevated, keep them calm to prevent laryngospasms, and then continue that antibiotics. Maintain hydration with fluid, monitor INO, their weight, vital signs SaO2, and a really good solid respiratory assessment. Emotional support is going to be very important for the child and family. The child is anxious and fearful. The parents are very anxious because their child is in the ICU. The child is fearful because obviously they're in a strange place. So it is important to allow 24-hour visiting and explain everything that you're doing to the parents of what you're doing to the child. Laryngotracheobronchitis, also called LTB. So this is a viral type of croup, and this is occurs in the larynx and trachea. Typically, this is seen 6 months to 3 years of age, primarily in children under 5. So this has a more gradual onset. They have the signs and symptoms of a upper respiratory infection, inspiratory stridor, a seal-like barking cough, hoarseness, shortness of breath, irritability, and a low fever. There are 4 stages of LTB. Stage 1 is fear, hoarseness, a croupy cough, inspiratory stridor, and this inspiratory stridor occurs when they are disturbed. This is a phase typically they can be managed at home. If they progress to stage 2, then they need to come to the hospital. So stage 2 is continuous respiratory stridor, low rib retractions, retractions of the soft tissue of the neck, accessory muscle use, and labored breathing. Stage 3, signs of anoxia, carbon dioxide retention, restlessness, anxiety, pallor, sweating, and rapid respirations. Stage 4, intermittent cyanosis, permanent cyanosis, and cessation of breathing. Diagnosis, the physical exam. Again, here we're also going to avoid the throat culture and inner mouth exam just for safety's sake. They will do an x-ray of the upper airway. Here you'll see symmetrical subglottal narrowing. This is also called steeple sign. And of course, we're going to be monitoring that SaO2. Treatment, humidification, oxygen if their SaO2 is low, racemic epinephrine, corticosteroids, and albuterol. These will help with bronchodilation, reduce bronchospasms, as well as reducing edema. They will increase fluids to thin the secretions. If the respiratory rate, especially in your younger children, is greater than 60, they are going to be NPO because there is a risk for aspirations. Again, if the symptoms are stage 1, they may be able to be treated at home, and then you want to teach them the signs and symptoms of increasing distress so that they know when to come back to the hospital. As a nurse, we want to monitor their vital signs, their respiratory status, effort, stridor, retractions, color, level of consciousness. Note that the breath sounds decrease, and as the level of consciousness changes, the child is becoming sicker. You want to position the child in a comfortable position. So note that as they're sitting more upright, they're having more respiratory difficulty. You want to check the child often for inability to swallow, drooling, and decreased voice sounds. The quieter the child gets, the worse the situation. The child is becoming physically exhausted, and they may actually go into respiratory failure. So a nursing alert is early signs of impending airway obstruction include increased pulse and respiratory rate, substernal, suprasternal, and intercostal retractions, nasal flaring, and increased restlessness. Bronchitis. This is an inflammation of the large airway, usually associated with an upper respiratory infection. Most often it's viral in nature. Signs and symptoms, dry hacking, non-productive cough, that gets worse at night, and then it becomes productive in 2 to 3 days, in addition to all the other typical upper respiratory infection signs and symptoms. Treatment, analgesics, antipyretics, humidity, cough suppressants only to allow the child to rest and sleep at night if they're over 6 years of age. Studies show that honey is a very effective treatment for coughs. But remember, we do not give honey to anybody 1 year and under. Typically, this can last around 5 to 10 days. Bronchiolitis. This is an infection that causes inflammation and obstruction of the small airways and bronchioles. One of the virus is respiratory syncytial virus that can cause this condition. So it's not uncommon to see bronchiolitis, also called RSV. This is often seen in children ages 2 or less. Peak incidence is 6 months of age. We see this primarily in the winter and spring. Signs and symptoms, well, basically it starts as an upper respiratory infection. So rhinorrhea, pharyngitis, coughing, sneezing, wheezing, a possible ear or eye drainage, intermittent fever, and then as the illness progresses, they can have increased coughing and wheezing, fever, tachypnea, retractions, refusal to nurse or bottle feed, copious secretions. And as they become more severely ill, hopefully it doesn't get to this point, they can have tachypnea, respiratory rate greater than 70 breaths per minute, listlessness, apnea, altered air exchange, poor air exchange, and poor breath sounds. Diagnosis. So this is only if needed. They can do a rapid immunofluorescent antibody, direct fluorescent antibody staining, or ELISA techniques. These are used for RSV antigen detection via a nasopharyngeal wash for RSV. Note that the cultures are becoming obsolete. If positive, you want to place the child in droplet and contact isolation. They may be in a room with other children that have RSV. Treatment, vital signs, monitoring that respiratory sounds, effort, assessing the cough, what is their SaO2, strict INO, weigh them, provide a high flow nasal cannula oxygen to keep the oxygen above 90%. Hydration through oral or IV, nebulizing treatments, bronchodilators and or steroids. Ribavirin, which is an antiviral agent, is an aerosolized treatment to decrease the severity of RSV. This is really only used for high mortality risk infants and transplant patients. The problem with this medication is that it has severe teratogenic effects. You must protect pregnant health care givers. When using, stop the treatment if you're going to be opening up the tent so that the particles don't get out of the area. The skin does not absorb the medication, so gowns and gloves are not required when handling the medication. You do want to maintain the head of the bed elevated, suction as needed only. Parents are taught how to instill normal saline drops into the nares and suction the mucus with the bulb syringe before feeding and before bedtime, and that makes it so that the child can more easily eat and rest and sleep. To address the issue of decreased fluid intake, the parent may offer small amounts of fluids of 5 to 10 milliliters at a time using a medication syringe every 10 minutes or so, really to help maintain hydration. You want to maintain their rest. We want to encourage parents to visit and ask questions. We want them to help with the ADLs as necessary. And if they're too exhausted, obviously we can do that. We, of course, always want to adapt our care to the child's development, and then making sure the parents do know how to use a bulb syringe. Palivizumab, also called Synagis, is an IM Q-month times 5 injection that can be used to prevent RSV for high-risk patients. Most often, you're going to see the high-risk group being like your premature babies. The powder needs to be used within 6 hours of mixing because there are no preservatives. Discharge instructions, you want to call the doctor if the respiratory rate increases. There's an increase in shortness of breath, decrease in eating or sleeping. You see an increase in fatigue. If the child is looking or acting sicker, anytime you have persistent signs and symptoms in a child less than a year of age, or a child that has a heart or lung problems, or they're premature, you want to give the doc a call. Asthma. So asthma is a chronic inflammatory disorder of the airway. Clinical manifestations include coughing, so it's a hacking, paroxysmal, irritative, often non-productive. Later, it can become more rattling and productive, and you'll see like frothy, clear, gelatinous sputum. Respiratory signs would be things like shortness of breath, prolonged expiratory phase, an audible wheeze, decreasing to absent wheezing with increased rate. This can actually indicate impending respiratory failure. They can have a malar flush and red ears. Lips can be a deep, dark red color. They can then progress to cyanosis of the nail beds and or circumoral cyanosis. Restlessness, apprehension, sweating may be prominent as the attack progresses. Older children may sit upright with their shoulders in a hunched over position, hands on the bed or chair with the arms braced. They might actually be speaking with very short, panting, broken phrases. The chest, here you would see hyperresonance on percussion, coarse, loud breath sounds, wheezing throughout the lung fields, prolonged expiration, crackles, generalized inspiration and expiratory wheezing, increasingly high-pitched. And as a child has repeated asthma attacks, they can develop barrel chest, elevated shoulders. You can see accessory muscles of respiration. The facial appearance, you'll see flattened molar bones, circles beneath the eyes, a narrow nose, and prominent upper teeth. So diagnosis, they can do pulmonary function test, and these can be done fairly reliably in children 5 to 6 years of age. They can use a peak flow meter and a chest x-ray. Medications. We've got two categories: long-term control medications to achieve and maintain control of inflammation, and quick relief medications to treat symptoms and exacerbations. Bronchodilators like your beta agonists, your albuterol, your levoalbuterol, and your terbutaline, these relax smooth muscles in the airway, the drug of choice for acute or daily therapy. Side effects here include things like tachycardia, nervousness, nausea and vomiting, and headaches. Methylxanthines. Theophylline is an example of this. This relaxes the muscle bundles that constrict the airways. They dilate the airway, provide continuous airway relaxation. This is used for long-term control, so continuous administration is needed. This works best when a specific amount is maintained in the bloodstream. The therapeutic level is 5 to 15 micrograms per milliliter. They need to require serum level checks and dose adjustments. They can have quite a few side effects. Things like early side effects include nausea, irritability, tachycardia. Some later side effects include arrhythmias, seizures, and then some other general side effects include restlessness, tremors, insomnia, hypotension, severe headache, vomiting, and diarrhea. Anti-inflammatory medications like your corticosteroids, basically these effectively reduce mucosal edema in the airways. Side effects include increased glucose and sodium, decreased potassium, weight gain, increased appetite, fluid retention, moon face, mood alterations, hypertension, growth retardation with long-term use. Inhaled corticosteroids, budesonide, and fluticasone are examples. These are recommended as a first-line therapy in children over 5 years of age. Although evidence does not show long-term significant effects on growth of the bone density, ocular toxicity, or suppression of the adrenal pituitary axis, they should be monitored every 3 to 6 months. Salmeterol or Ceravent is a long-acting beta-2 agonist, and this is used every 12 hours for bronchodilation. It's used with an anti-inflammatory for long-term prevention. This can only be used in children over 4 years of age. Cromolyn sodium. This is a preventative medication best taken daily to stop chemical-associated triggers that produce asthma. You want to use it at least 10 to 20 minutes before coming in contact with something that can trigger your asthma. This is not a rescue medication. Leukotriene modifiers, these block inflammatory and bronchospasm effects. They are used for long-term control in combination with the beta-2 agonists and steroids. Singulair or montelukast sodium is used for kids 12 months and over. Accolade or zafirlukast is approved for 5 years and over. Xolair or omalizumab blocks the binding of the IgE to mast cells. This eventually inhibits inflammation. It is given subcutaneous once or twice monthly for kids 12 years old and older for moderate to severe asthma that's not responsive to inhaled corticosteroids. This does have a black box warning for anaphylaxis. Magnesium sulfate, this is a potent muscle relaxant to decrease inflammation. It can be used IV or inhalation. This is typically used in the ICU or ED for acute exacerbations. So nursing, obviously we're going to be using oxygen as needed. It can be through the nasal cannula or a mask with humidification. They need to be in a semi to high hours position, monitoring your vital signs and the respiratory effort, lung sounds, pay attention to the bronchodilating meds and their side effects, maintain good hydration to thin the mucus, strict intake and output, monitoring the weight. We want to promote relaxation due to the fatigue. Know that chest physiotherapy and peak flow readings can be done fairly reliably in children 5 to 6 years of age. You want to keep the peak flow meter readings in the green zone, and we'll talk about the green zone in just a moment. In terms of follow-up, you want to teach parents CPT, inhaler and nebulizing treatment use, the medication regime and side effects. You want to avoid cold fluids and cold air because this can actually cause bronchospasm. So cover the nose and mouth with a scarf when they are going outside when it is cold. Teach parents to be aware of asthma triggers and avoid them. If the child has difficulty coordinating breathing when using an inhaler, you can use a spacer. Children 5 years old and older should use a peak flow meter to determine how they are doing. This can be done by having the child stand straight, inhale, and then blow hard and fast. This is done 3 times, and then the highest result is recorded. It can take maybe 2 to 3 weeks to determine a child's personal best. And then this is going to be used for comparison as the child does this as ordered when they are at home. It is done routinely and then before and after treatments. So how do we interpret peak flow readings? So if you are in the green zone, this means you are in the 80% to 100% of your personal best. So remember, we said it takes 2 to 3 weeks to determine the personal best. So once you've determined that, then you can do this. And this is great. You know, green is good. It signals it's all clear. Asthma is under reasonably good control. No symptoms are present. The routine treatment of plan for maintaining control can continue to be followed. Yellow is 50 to 79% of the personal best. So yellow, think like a street lights, caution. The asthma is not well controlled. An acute exacerbation may be present. The maintenance therapy may need to be increased. They may want to call the practitioner if the child stays in this zone. Red. So this is less than 50% of the personal best. This is actually a medical alert. You've got severe airway narrowing. There may be some significant issues. A short-acting bronchodilator should be administered. You want to notify the practitioner if the peak flow rate does not return immediately or if they stay in the yellow zone. Swimming is a great exercise because of the type of breathing that is required and the moisture. Please note that bedding and clothes should be washed in 130-degree water, which remember we said for safety, we want to keep the water heater at 120. This is sort of an exception to that rule because we want the sheets as well as the clothes to be washed at a little higher level. You want a damp wipe instead of dust, because if you just dust, you're having all the particles fly over the house, and that's just not helping somebody that has asthma. Ideally, also, they don't have curtains or carpets because, again, the dust can trigger asthma. The good news is that children develop immunity by about 5 years of age. So usually 5 and older, they're going to have less issues with getting so many upper respiratory infections. Lastly, we're going to talk about cystic fibrosis. This is an inherited autosomal recessive disorder involving the exocrine glands that affect the respiratory, GI, GU, skin, and musculoskeletal systems. Body organs and mucus ducts get obstructed and damaged due to thick, sticky mucus production. Signs and symptoms. So we've got the 4 F's for the stool characteristics of cystic fibrosis. So the stool is frothy, foul-smelling, fatty, and it floats. The child's skin, actually, so parents will be kissing their children and they will say the skin tastes salty. Meconium ileus is something that they might see. So here you'll see abdominal distension, vomiting, failure to pass stools, rapid development of dehydration. Gastrointestinal manifestations include those large, bulky, loose, frothy, very foul-smelling stools. Early on in the disease, they have a very voracious appetite. Later on in the disease, they may have a loss of appetite, weight loss, and tissue wasting, failure to grow, a distended abdomen, thin extremities, sallow skin, and then evidence of a deficiency of the fat-soluble vitamins. And these vitamins are A, D, E, and K. They also may be very anemic. The pulmonary manifestations, here signs include like wheezy respirations, dry non-productive cough. Eventually they can develop dyspnea, paroxysmal cough, evidence of obstructive emphysema, and patchy areas of atelectasis. As things progress, they can have overinflated barrel-shaped chest, cyanosis, clubbing of the fingers and the toes, and they will develop repeated episodes of bronchitis and bronchial pneumonia. Diagnosis. So there is a universal screening test that is available across the United States. It's an immunoreactive tryptosinogen test. The positive screen identifies children at risk. The sweat chloride test, basically the chloride is greater than 60 milliequivalents per liter with the above signs and symptoms. They will also do chest x-rays and a stool diagnostic test. A sweat chloride test of 59 to 30 milliequivalents per liter is indeterminate and really does need to be repeated. And I already mentioned that the parents will say that their children taste salty. DNA testing for a mutation on the CFTR gene predicts with a high degree of certainty a diagnosis of cystic fibrosis. So treatment, really what we want to do is prevent or minimize pulmonary complications, promote nutrition, promote age-appropriate physical activity, and promote a reasonable quality of life. So respiratory, we need to think about airway clearance therapies, also called chest physiotherapy. It needs to be done at least twice a day before meals, possibly more, like I said, if needed. PPD, which is percussion and postural drainage. Please note that it's contraindicated to put an infant with the head down during CPT. They can do something called a flutter mucus clearance device. This is basically a small handheld plastic pipe with a stainless steel ball inside of it. And this helps to facilitate the removal of mucus. So we can see that in children. High frequency chest compression is accomplished by using a mechanical chest device that is worn for periodic treatments during the day. This provides rapid entry and exit of air in the lungs and assists with mucus breakdown and clearance. Bronchodilators help to ease expectoration. Pulmazine or DNase decreases the viscosity of mucus. Some of the side effects of this include voice alterations and laryngitis. You want to give daily before the PPD. Antibiotics orally, IV, or aerosolized may also be used. Oxygen is often used for acute problems, but you want to use it cautiously. With repeated infection and inflammation, bronchial cysts and emphysema may develop. Know that these cysts may rupture and can result in pneumothorax. So nursing alert, signs of pneumothorax are usually nonspecific and include tachypnea, tachycardia, dyspnea, pallor, and cyanosis. A subtle drop in oxygen saturation, which is measured by pulse oximetry, may be an early sign of pneumothorax. Know that it is very important to maintain IV access in these children. It's not uncommon for them to have a PICC line or a central line. Nutrition, they need pancreatic enzymes, or these can be called pancrelipase, at the beginning of meals and snacks for digestion of nutrients and decrease fat and bulk of the stools. Basically, by taking this is going to decrease the bulk of the stool, and we want to decrease these to a day, okay? They need water-soluble forms of the fat-soluble vitamins, which are vitamins A, D, E, and K. They need a well-balanced, high-protein diet. They also need, fat as tolerated. More enzymes are required when they're eating higher fat foods. They need from anywhere from 110 to 200% of the calories of the standard healthy person to meet their growth needs. An increase in salt intake due to a loss in sweat or an increase in exercise, fever, or hot temperatures. So pay attention. This is one of the few times that we don't say low salt. We want them to have salt. And growth needs to be monitored frequently. Meconium ileus obstruction or constipation can occur. Here, treatment involves colightly, Marilax, laxatives, stool softeners, or rectal administration of gastrogafin. Rectal prolapses can occur, and here what you would just do is just very gently use a lubricated gloved finger and guide the rectum back into place. And then you need to make sure that you're decreasing the bulk of the daily stools with the pancreatic enzymes. So they may need more pancreatic enzymes. Cystic fibrosis related diabetes can occur. It is diagnosed with an oral glucose tolerance test. They require close monitoring of blood glucose, insulin administration, diet, exercise management, and quarterly hemoglobin A1C measurements. During illness exacerbations, know that hyperglycemia may occur. Median survival age as of 2020 is 37 years of age. So this concludes this topic. Please remember to watch the other presentations that are assigned this week. Thank you and have a good day.